Hey everyone, so this is going to be part of 3 sets going over diabetes mellitus, and this is going to focus on the pathophysiology of diabetes, the medications used, the oral and injectable medications that are used, excluding insulin, and some of the acute complications. So, what is diabetes? So, diabetes affects 10% of all Americans, and out of those, 9 out of 10 suffer from type 2 diabetes. So, the terms type 1 and type 2 diabetes are the appropriate terms to use. There are old-fashioned terms that are used. They're really not so much accurate. So type 1 used to be called juvenile onset diabetes or insulin-dependent diabetes. And type 2 used to be called adult onset diabetes and non-insulin dependent diabetes. And I'll tell you in a little bit why those are inaccurate terms. So type 1 diabetes mellitus tends to occur in leaner patients. It tends to occur in younger patients, and it always requires insulin. Always, always, always. And in the cause behind it is an autoimmune destruction of the beta cells in the pancreas, which are the cells that release insulin. They make and release insulin. So if those cells are destroyed, then you're not going to have insulin release. This tends to occur in children because autoimmune diseases can happen in children. However, it can also have an onset in adulthood. So it's not necessarily juvenile onset. But it does always require insulin. Now, type 2 diabetes tends to occur in chronically overweight and obese patients and often can be controlled by appropriate diet and exercise, but usually is going to require oral medication in addition to that diet and exercise. Type 2 diabetes may require insulin. If the patient is not able to get their glycemic control in rein while they're on oral medications, they may require insulin. And as a matter of fact, as most type 2 diabetics progress in their illness, their insulin resistance becomes so severe that they actually stop responding to insulin at all. And as a matter of fact, their beta cells can become so overwhelmed and so overworked that they can actually just stop secreting any appreciable amount of insulin. So really, type 2 diabetics can become insulin dependent. So it's not appropriate to call type 2 diabetes non-insulin dependent diabetes. And also, type 2 diabetes, because of the obesity pandemic, has been starting to occur in younger patients, even children. So to call it adult onset diabetes would also be not necessarily accurate. Diabetes is important to know about inside and out because it is a huge cause of morbidity in the U.S., and particularly patients that you're going to see in the hospital. They're sick patients, they tend to be overweight, they tend to be older, and therefore they tend to have diabetes. Complications from diabetes, there are a lot of them. We're going to only talk about the emergent ones on this set of slides, but I've devoted an entire set of slides to talk about the rest of them. The emergent ones are diabetic ketoacidosis and hyperosmolar hyperglycemic state, which used to be known as hyperketotic hyperosmolar coma. We also have microvascular complications, which can lead to neuropathy, macrovascular complications, which can lead to nephropathy, and then the neuropathic complications. Okay, so how does diabetes present? Well, regardless of whether it's type 1 or type 2 diabetes, the symptoms tend to be pretty similar. The history is where it's going to be different. So the symptoms of diabetes is polyuria, polydipsia, and polyphagia. Why? Because if you don't have insulin or you're not responding to insulin, your cells are not getting any sugar. And so as far as your body is concerned, you're starving. Even though you got all that sugar in your circulation, your body thinks it's starving because it can't get the sugar in to the cells. Remember, insulin is needed to transport glucose into the cells. So some patients, particularly type 1 diabetics, because they're not overweight, because they don't have any other symptoms, because we don't we don't screen them for diabetes. Some type 1 diabetics will present with diabetic ketoacidosis, and that's actually quite common because we're not screening children for diabetes. Now, adults, on the other hand, if you have an overweight 48-year-old man, yeah, you're going to screen him for diabetes. You're probably going to have a past glucose level on him, and if it's elevated, you might think, okay, we got to test you for diabetes before it gets to the point where he has a major complication. Now, some type 2 diabetics will present with hyperosmolar hyperglycemic syndrome, but the nature of hyperosmolar hyperglycemic syndrome is that these patients are severely dehydrated, and that doesn't happen usually in patients who can get out and about and are able-bodied. That usually happens more in sick and infirmed and older patients. So it's very rare for type 2 diabetes to present with hyperosmolar hyperglycemic syndrome. Also, diabetes can present with the overt microvascular and macrovascular or neuropathic symptoms of diabetes. So diabetes may present with peripheral neuropathy. It may present with gastropathy. So in that case, then you'd have to take that into consideration. So how do we diagnose diabetes? If the patient has symptoms, and this is rare, so let's say the patient has peripheral neuropathy or has symptoms of gastropathy, and you get a random blood glucose and it happens to be over 200, if they have symptoms consistent with diabetes, as far as the complications of diabetes, you can diagnose them just based on that random blood glucose. But this is generally not how patients are diagnosed with diabetes. Usually we diagnose them earlier on. So if the patient doesn't have symptoms, which is usually the case, when you're screening a 40-year-old patient, usually I think it's age 40 we start screening for diabetes. If the patient doesn't have symptoms, what we do is when we screen the patient, we have them fast, and usually this is going to be when we're also screening their lipid levels because they have to fast for that too. They fast overnight. If their glucose levels are 126 or greater, so this should be greater than or equal to 126. That is considered an abnormal glucose level. And it's not enough, though, to just have that one abnormality. They're going to have to come back and do the test over again, having been fasted, and have another abnormal result. Once you get 2 abnormal fasting blood glucose results, that is diagnostic of diabetes. Now, the oral glucose tolerance test is not so much used anymore for routinely diagnosing diabetes mellitus. That's more for diagnosing gestational diabetes, which I'll talk about in a different section. So that's not for diagnosing diabetes mellitus anymore. Now, once you've diagnosed a patient with diabetes, the next best step, assuming that the patient is stable, they're not the DKA patient or an HHS patient, they don't have any other symptoms that need to be treated, the next step in managing their diabetes is to get a hemoglobin A1C level. Because when we diagnose this patient with diabetes, it's unlikely that they just developed the diabetes yesterday. They probably had it for a while, and so we want to see how bad it is. And that will help us decide how to treat the patient. So what is hemoglobin A1C? It's a measurement of glycosylated hemoglobin, and it's in a percentage. So out of all your hemoglobin, a certain percent of it is glycosylated, and that percent is your hemoglobin A1C. It provides the practitioner with an idea of how the diabetes has been controlled over the past 3 months. And for a person who doesn't have diabetes, so the normal level for a non-diabetic patient is 4.5 to 6%. Now, there's 3 ranges of A1C that's going to help us dictate therapy, and these are based on the new ADA guidelines, and these just came out in the past spring. Actually, I believe it's the American College of Clinical Endocrinologists just came out with these new guidelines. So you might not see these in some of your review books, but these are new for 2013. So I would remember this and definitely remember it for the clinic. So there's 3 levels of A1C. So you've got a new patient with diabetes. They come in, you get their A1C, and you look at what their A1C level is. There's 3 thresholds: less than 7.5, 7.5 to 9, or greater than 9.0. So formerly, the best step in management was to start the new diabetic on a protocol of diet and exercise, have them come back in another month, and then check their A1C levels to see if it's improved, or in 3 months. While that's still recommended that they get diet and exercise, at this point now, we generally treat all type 2 diabetics with some kind of anti-hyperglycemic medication. So in addition to starting with diet and exercise, we add metformin. So remember I said those 3 levels, 7.5, 7.5 to 9, and greater than 9. If the patient has less than 7.5% A1C, you can start them on monotherapy. You could start them on diet and exercise, but like I said, the American Academy of Clinical Endocrinologists, they now recommend just starting right off with monotherapy in addition to diet and exercise. It's almost always that we use metformin. Metformin is much safer than the sulfonylureas and thiazolidinediones, and it's much more effective. So metformin is the drug of choice for monotherapy, unless it's contraindicated. And we don't use metformin in patients with renal disease or with liver or lung disease. And that's because one of the adverse effects of metformin is acidemia. So 7.5 to 9.0, if they test in that range, then we tend to start them out on dual therapy. And we'll start them out on metformin, of course something else if it's contraindicated, and then add another medication. If they're greater than 9.0 and the patient has diabetic complications, so they have neuropathy, they have an increased creatinine, they have, let's say they've got gastropathy, then we're going to start them on insulin therapy. If the patient does not have symptoms, then we're going to start them on triple therapy. So they'll be on metformin and then 2 other medications if necessary. Metformin and then 2 other medications. So as I mentioned, metformin is contraindicated in patients with renal failure, liver disease, or lung disease, and that's because of the risk of lactic acidosis. So what are the drugs that we use in diabetes? The first drug that we're going to go to, it's the cornerstone of therapy. It has been and it still is, despite the new recommendations, it continues to be metformin. So metformin is one of the most studied diabetic drugs, and so we still go to it as the first drug. Now, one of the exceptions to that is if the patient has renal, liver, or lung disease. And the reason for that is because one of the dangerous side effects for metformin is lactic acidosis. But unless the patient has renal, liver, or lung disease, the first drug we're going to go to is metformin. The sulfonylureas, unfortunately, are falling out of favor because of 2 side effects. One, it can cause hypoglycemia if it's not appropriately dosed. And 2, it is notoriously known for causing weight gain. So that reduces a patient's compliance with their diabetic medication. I wouldn't want to take a drug either if it made me gain 40 pounds in the first 6 months of therapy. So sulfonylureas are generally falling out of favor. But you can use a sulfonylurea as a first line of therapy if the patient cannot be on metformin for one reason or another. Thiazolidinediones include pioglitazone and rosiglitazone. Those this is also an older drug. One of the nasty side effects from the thiazolidinediones is that it increases the plasma volume. It can cause edema, and so this is a problem if patients have congestive heart failure. But I would say it's more patients comply with the thiazolidinediones better than metformin. Better than sulfonylureas rather. It also does not cause weight loss or weight gain. So if a patient is on a sulfonylurea and they want to be on something, if they're on dual therapy with metformin and they want to be on something that's not going to make them gain weight, and they can't afford one of the newer drugs, then switching to thiazolidinedione would be fine. The only patients I would not prescribe it in are patients with congestive heart failure. Now, the next two classes of drugs, and there's a couple other classes of drugs I didn't include here just for brevity, but these two classes of drugs are very commonly used, and these are newer, the GLP-1 agonists and the DPP-4 inhibitors. And these are secretagogues, and the GLP-1 agonists are newer, and they're very, 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 well, they're very good drugs, let me put it that way, because a lot of your patients with type 2 diabetes are going to be overweight or obese. The GLP-1 agonists have the singular positive effect out of all of the anti-hyperglycemics of causing weight loss. And so this would be a great drug to give to a patient who's overweight, otherwise healthy, has type 2 diabetes. The only problem with it is that it's an injectable drug. And so these patients have to take it subdermally. Now, a lot of patients are very happily surprised by how easy and unobtrusive it is. It's painless, but that's something that you'd have to teach the patient. It's also kind of expensive, so that's another downside. But this is a great drug for patients who are not happy in the sulfonylureas and thiazolidinediones, and they've got insurance, and it will cover GLP-1 agonists. What the GLP-1 agonists do is they are an agonist for a protein that increases the secretion of insulin. So they're working at the beta cell. They are a secretagogue. GLP-1 agonists are contraindicated in patients who have medullary thyroid carcinoma or MEN type 2 syndrome, which is multiple endocrine neoplasia type 2 syndrome. It's also advised that patients stop GLP-1 agonists if they develop symptoms of pancreatitis. DPP-4 inhibitors include sitagliptin and linagliptin. What the DPP-4 inhibitor is, well, DPP-4 is a protein that causes the breakdown of the GLP-1 protein. So by taking a DPP-4 inhibitor, you're actually going to increase your endogenous concentration of GLP-1. So they kind of do the same thing. The difference is that DPP-4 inhibitors are weight neutral, so they're not going to cause weight loss, and DPP-4 inhibitors are also taken orally. So that's another upside for patients that are needle phobic. This also is a drug that if the patient develops symptoms of pancreatitis, it should be stopped and not restarted. Okay, metformin is going into detail on that. So along with diet and exercise, this is a cornerstone of therapy in type 2 diabetics. Barring any contraindications, this is the best initial pharmacologic management. The adverse effects include lactic acidosis and GI upset. Okay, so the sulfonylureas, as I mentioned, these are kind of falling out of favor, and it's for two reasons. One, they're notoriously known to cause weight gain in diabetic patients, and that's generally a problem because most patients who have diabetes are already struggling with their weight. So to put on 20 or 30 pounds in a year while they're trying to make positive changes in their life by getting their diabetes under control, that's not really a fun thing for them. So weight gain is a problem with sulfonylureas. There's also an increased risk of hypoglycemia, and along with insulin, it is one of the most common diabetic drugs that can cause hypoglycemia. So for those two reasons, it is falling out of favor. Nevertheless, it can still be an appropriate monotherapy, particularly in patients where metformin is contraindicated. The thiazolidinediones, which include pioglitazone and rosiglitazone, these are also sort of falling out of favor. And that's because these can cause liver disturbances. Patients who are on TZDs have to come in and get their liver panels checked approximately every 3 months. And they cause water retention, which can manifest as edema. And so you want to try to avoid using thiazolidinediones in patients with congestive heart failure or in patients with COPD. They still, again, can be appropriate monotherapy in patients in whom metformin is contraindicated. The thing that thiazolidinediones have over sulfonylureas is that thiazolidinediones are weight neutral, and so they will not cause that sort of weight gain that sulfonylureas cause. Okay, now let's get to some of the newer drugs. The GLP-1 agonists. So these are very attractive choices, and then the reason that these are so attractive is because the GLP-1 agonists can cause weight loss, and that is something that most diabetics need. So it's effective in two ways, in that it lowers your blood glucose, and it also causes weight loss. So the one problem with this is that it's taken by injection. However, the injection, the needle is really, really, really thin, and a lot of patients are pleasantly surprised with how non-obtrusive and painless this is. So a lot of patients aren't going to have any problem doing this, and particularly when you talk to patients who are overweight and you tell them that this can be associated with weight loss, this is something that patients will want to do. The problem with it is that it's expensive. There are very few adverse effects with the GLP-1 agonists. However, there are some contraindications. Patients with multiple endocrine neoplasia type 2 disease, which is a genetic disease, it's contraindicated in those patients because they're at risk of medullary thyroid cancer. And in any patient with a history of medullary thyroid cancer, GLP-1 agonists are contraindicated. They are associated with an increased risk of medullary thyroid cancer in patients who already have a genetic predisposition to developing that condition. GLP-1 agonists can be associated with acute pancreatitis. There's no causal link between GLP-1 agonists and pancreatitis, but it is recommended that if the patient starts to develop the symptoms of acute pancreatitis, that gnawing pain, back pain, they should stop taking their drug and see a doctor as soon as possible. Exenatide and liraglutide have been marketed as Byetta and Victoza, and they still are under patent. The DPP-4 inhibitors. So DPP-4 inhibitors, I want to start by talking about their mechanism. So remember, the GLP-1 agonists, those work by increasing the secretion of insulin in the beta cells. What DPP-4 is, DPP-4, not a DPP-4 inhibitor, but just DPP-4 itself, is an enzyme. And that enzyme breaks down GLP-1, which has a very, very short half-life, like 2 hours. And it breaks it down into inactive breakdown products. So if you inhibit DPP-4, you're going to prolong the half-life of GLP-1, and therefore you're going to have an increased insulin secretion. So that's a good thing if you want to reduce your blood sugar. DPP-4 inhibitors are weight neutral, and the thing that they have over the GLP-1 agonists is that they're taken orally. So a lot of patients would prefer that, but they are weight neutral. But that can be good if you have a real thin patient that you don't want to lose any weight. DPP-4 inhibitors have very few adverse effects. The one most prominent that happens in about 1 in every 3 patients is nausea and vomiting. But as long as you warn the patient that those symptoms could come up, they tend to be pretty compliant. Like the GLP-1 agonists, they should not take these if they have symptoms of acute pancreatitis, and this is something that you should counsel the patient about before you put them on these drugs. A DPP-4 inhibitor can be an attractive choice in a patient who's contraindicated for GLP-1 agonists, particularly because of the thyroid cancer contraindication. A DPP-4 inhibitor can be an attractive choice. Okay, so back to how we treat diabetes mellitus. So remember that once a patient has established their diagnosis, then we get an A1C level, and the old way used to be to just start diet and exercise and see if they come back. But the fact is that the American Academy of Clinical Endocrinologists have said that usually fails, and so we should just go to start treating them medically as soon as they're diagnosed. And so less than 7.5%, they should be on monotherapy. Almost always that's metformin unless it's contraindicated. If they're between 7.5 and 9, we'll have them on dual therapy, Generally, that will be metformin plus another medication. Usually, we would prefer to put them on the DPP-4 inhibitor or the GLP-1 agonist, but we can also use the sulfonylurea or the thiazolidinedione. If the patient's greater than 9%, you have to ask yourself, does the patient have complications? Do they have neuropathy? Do they have nephropathy? Do they have gastroparesis? Do they have visual loss? In that case, you should start insulin therapy. If the patient does not have any complications, then you're going to have them on triple therapy. So metformin plus 2 of the other anti-hyperglycemics. Okay, so when do we treat patients with insulin? So all patients with type 1 diabetes are treated with insulin. Any patient who presents with an A1C level of greater than 9 after they've been diagnosed with diabetes and they have complications, they should be treated with insulin. And any patient that cannot control their A1C levels with maximal therapy, they should be treated with insulin. Now, the downside to insulin is that you've got to inject it. It requires a certain level of compliance because you have to have your insulin supplies with you. You have to take it with you. If you're going to a restaurant, you have to make sure you have your insulin. And you have to be aware of your diet and exercise. Muscle can absorb glucose, and it doesn't need insulin to do that. So if you go out and run 3 miles, well, that's great that you're getting exercise. You got to watch out because you may need less insulin. And so it's always important to be taking your blood sugar before you inject your insulin, because if your blood sugar is 93 as opposed to 193, you do not want to be giving yourself insulin if it's before a meal, for instance. Okay, certain insulin regimens. Now, I have dedicated an entire section to insulin regimens because they're so important. And there are 4 different insulin regimens that are commonly used. There's the once daily basal insulin regimen, and that's usually used when a patient is also on some kind of anti-hyperglycemic. So you're just injecting a long-acting insulin either in the morning or at night. And that's just sort of supplementing your own basal insulin. So you're giving yourself kind of a kick up for your insulin. Usually that'll be with insulin glargine or insulin detamir. There's the twice daily basal insulin regimens, and this can be done without any kind of anti-hyperglycemic therapy. So you take a intermediate normal combination acting insulin in the morning and then in the evening. And those are usually your 70-30s or your 70-25s and your 50-50s. There's a basal bolus or prandial regimen, and that's where you take, it's sort of a combination of a once daily basal regimen where you're taking a long-acting insulin in the morning or in the evening, and then before each meal, you're going to supplement it with a quicker acting insulin. And then there's a sliding scale regimen. That tends to be used in hospitals. And in sliding scale regimens, you take the patient's blood glucose every 4 to 6 hours, and then you'll give them normal insulin based on that. That's preferable in hospitals because a lot of patients in hospitals are on different drugs. They may have infections. They may have inflammation, which would cause an alteration in glucose levels. And so it's useful to just respond directly to their glucose levels since they're in the hospital and there's professionals around who can monitor that. Okay, so what are the emergent complications of diabetes? So we talked about this a little bit earlier. These are not These are emergent complications of diabetes. So this isn't something that's supposed to happen. This is something that goes terribly wrong if the patient's not being treated. If a patient's treated, they should not be getting these things. So there's diabetic ketoacidosis. This only occurs in type 1 diabetics, and because type 1 diabetics can be children, and we don't screen children for diabetes, it can be a presenting sign of diabetes. This could be the first manifestation of their diabetes. And then there's hyperosmolar hyperglycemic state, HHS. This tends to occur on type 2 diabetics, but it tends to occur because a patient is either non-compliant or they're older and infirmed and they can't drink water. Okay, so diabetic ketoacidosis. So what is this? This is something that type 1 diabetics can present with, and that's important to remember. You may have a patient that presents with diabetic ketoacidosis that does not have a history of diabetes. A lot of times, usually this is going to happen in children, and that's because type 1 diabetes is generally juvenile onset, but you can't rule it out just because you have an adult patient. So what's happening here? In DKA, you have a severe insulin deficiency, and it's severe enough to where the cells are going to shift to lipolysis. Now, why is this? Well, in your blood, you have a ton of glucose. So why do the cells need to shift to lipolysis? If you don't have insulin, then your cells, as far as they're concerned, they're starving because they're not getting glucose in. And once they get to the point where they're starving enough, they're going to shift their metabolism to breaking down fat. And anytime you break down fat, you create what are called ketone bodies. Now that's fine to a certain extent. You could go on a low-carb diet and create ketone bodies, but you don't do it to the extent that patients with DKA who have absolutely no glucose in their cells are doing it. And when these ketone bodies spill out into the blood, if there's enough of these ketone bodies, it can actually precipitate an acidemia, and that's because these ketone bodies they're acidic. And so, what you can do is you'll note this when you check your anion gap. You will have an acidemia, but you'll have a proton that's not contributing to your anion gap. So you have your anion gap is sodium, potassium subtracted by bicarb and chloride. And so the ketone body is not included in that, and so the anion gap will be high because the ketone body is not included in that equation. So a lot of times DKA is going to be precipitated by some kind of inflammatory process, so it's not unusual for an infection to spur on the DKA. Non-compliance with insulin regimen and illicit drug use can also spur on DKA. And that's really because in any kind of inflammation, you're getting an increase in your metabolic rate, so the cells are going to demand more energy. And it's the same with illicit drug use, particularly we see this with cocaine and methamphetamine. The symptoms of DKA are similar to the symptoms of diabetes, but they're going to be more pronounced. So polyuria and polydipsia are always present, nausea and vomiting, malaise and fatigue, and then you can get tachypnea and palpitations, abdominal pain, that's very present in DKA, reduced appetite, and at the end stages of DKA, as the acidemia progresses, altered level of consciousness, actually progressing to coma and death. On physical exam, you will see symptoms of hypovolemia, so dry skin and mucous membranes, reduced skin turgor. Patient could be hypotensive and tachycardic. A lot of times you'll see confusion, and the patient will often look very ill. They'll have sunken eyes. They may even be unconscious. The diagnosis is going to be clinical and based on labs. The most important labs that you can get are finger stick glucose, and I would say I'm arranging this in order of importance. So finger stick glucose would be the most important because you can rule out DKA if they got a normal glucose. So finger stick glucose, urinalysis with dipstick. The dipstick into the urine can tell you if you have ketone bodies, and that's a pretty good confirmation of DKA, along with an elevated glucose. A CMP is going to be important to check your electrolytes, and a CBC will be important to see if there's any kind of infection going on. Arterial blood gases and cultures are good as well, and you should also get an EKG on the patient because of some of the possible complications. And serum levels of hydroxybutyrate can be useful for monitoring the patient's response to therapy. So how are we going to make the diagnosis based on all these labs? The glucose level will always be greater than 250 milligrams per deciliter. Often it's much higher. I would say it tends to be around, even more than 500 or 600 milligrams per deciliter. So you're going to have a very high glucose. Your CBC is important because it could point you towards infection. Now, I want you to remember that white blood cells are always going to be increased regardless of whether there's an underlying infection. But if you have elevated neutrophils, an increased left shift, that suggests infection. So you should culture the blood no matter what, because infection can always be behind it. But a left shift or elevated neutrophils is suggestive of an active infection going on, which can spur on the DKA. With your urine, you're going to use a dipstick to check for glucose and ketones, and that can be done right away. If it's positive, which it should be highly positive, that's very suggestive of DKA. Your urinalysis will confirm this, and you should also culture the urine. Your metabolic profile will show you hyperkalemia and hyponatremia and a low bicarb. Why the hyperkalemia? Because potassium and glucose travel together. So if you have low insulin, you're not getting glucose into your cells, and so the glucose is remaining in the blood. That's why we get high glucose, and the potassium is going to remain in the blood, and that's causing the hyperkalemia. You'll have a hyponatremia as well and a low bicarb. This will result in a high anion gap, and that's suggesting both the presence of the ketone bodies and the fact that you have metabolic acidosis. Your arterial blood gases will confirm metabolic acidosis. Like I said, the hydroxybutyrate will be high, and this is a great way to have a laboratory indicator of how the patient's responding to therapy. So the treatment is going to be primarily based on your ABCs. So what are your ABCs? It's going to be airspace, breathing, and circulation. So the circulation here is at risk because these patients are at depleted fluid volume, and so you're going to want to replenish their fluid as quickly as you can. You'll want to start a normal saline bolus immediately. As soon as you see a patient that looks volume depleted, you're going to want to give a normal saline bolus. And you should actually give up to 3 liters of normal saline in the first hour. So as at least 1, but as many as 3 liters of normal saline in the first hour. So you're going to be using wide bores here. Another liter should be given in the second hour, and then another liter can be given over the subsequent 4. So you're going to be giving up to 5 liters of normal saline. So that's quite a bit. But these patients tend to be very volume depleted, and you've got to get that normal saline in as quickly as you can. Once you start administering the normal saline, then you can go ahead and administer insulin. And you're going to use normal insulin here. Normal insulin is a short-acting insulin. It doesn't work as quickly as Lispro or Aspart, but it works much quickly than NPH or Detamir or Glargine. So you're using normal insulin for DKA, and it works relatively quickly, and you're going to dose that at 0.1 units per kilogram per hour. You should be getting a CMP. You should have a CMP beforehand, and you should be getting your electrolytes frequently afterwards, probably at least every hour, because you're going to expect that this patient's going to go into a hypokalemia. Now, why is that? Well, they're starting out hyperkalemic, but even though the patient is hyperkalemic, they're only hyperkalemic because they're fluid deprived and because the potassium is unable to enter the cell. Once you start insulin, you're expecting, well, when you start insulin and your normal saline bolus, you're expecting, one, the blood is going to become more dilute as your volume status improves. And when insulin is administered, potassium is going to move out of the blood and into the cells. So you're going to expect a pretty quick drop in that potassium level. So you will go from hyperkalemia, and eventually you probably will go into a hypokalemia. So the rule is, and you're almost always going to be giving potassium to these patients, as you look at their potassium levels as they come back, if their potassium levels are more than 6, you're not going to be administering any potassium at all. Once it goes below 6, 4.5 to 6, you'll start them on 10 milliequivalents of potassium chloride. If it's between 3 and 4.5, you should administer 20 milliequivalents of potassium chloride, and if it's below 3, then you should stop the insulin. And this is another reason why EKG is important, because remember the effect that potassium can have on the heart, whether it's high or low. Now, the normal levels for potassium is 3 to 5.5, but notice that we're going to actually start administering potassium chloride at potassium level of 6, and that's because, again, we're expecting the patient to go into hypokalemia. And by hypokalemia, I mean we expect them to be at risk of hypokalemia. So we're treating it prophylactically, I should say. Along with treating the diabetic ketoacidosis, of course, we should be treating the underlying cause. If the patient has symptoms of pneumonia, we should be getting a chest x-ray. If they've got symptoms of UTI, meaning they've got elevated nitrites and red blood cells and white blood cells in their urine, we should be giving them an antibiotic for that. But treating the underlying cause is always going to be important. And then something that the USMLE likes to throw at you is, do you want to treat the patient with bicarbonate? And let's say the patient has an acidemia and they're 7.15. No, you're not going to treat them with bicarbonate. You're going to treat the underlying cause, and that should treat the acidosis. Now, at times you will give bicarbonate, but I would say on the USMLE, it's almost always the wrong answer. Bicarbonate is usually given when the patient is comatose and their acidosis is extremely severe. And by extremely severe, I mean less than 7.05, less than 7. But on the USMLE, bicarbonate is going to be generally the wrong answer. You're going to want to give fluid replacement, administer insulin, keep an eye out on those electrolytes, and replace potassium as needed. After the emergent treatment, of course, like I mentioned, the underlying cause should be found. All patients should be admitted to the general wards or to the ICU and put on a sliding scale. And that's while we search for a cause of the DKA. The patient can be discharged once the patient is well enough and we know that they're going to comply with their daily insulin regimen and the underlying cause is resolved. So if they still have pneumonia, if they still have a UTI, we're not letting them out yet. We want to fully resolve the underlying cause. And we must emphasize the importance of adhering to a strict insulin regimen. Okay, hyperosmolar hyperglycemic state. So this is formerly known as hyperosmolar non-ketotic coma, or HONC, H-O-N-K, or H-O-N-C. And this is different from DKA. So the reason that we changed the name is because patients can actually, with hyperosmolar non-ketotic coma, they can be positive for ketones. So you don't want to have the misinterpretation that just because the patient has positive ketones that they're diabetic ketoacidosis, because they might not be necessarily. So they may be positive for ketones, but it's not going to be as positive, and they're not going to be ketoacidotic. And also, we changed the name because not all patients are in a quote-unquote coma. There is almost always a decreased level of awareness, confusion, but they're not always going to be in a coma. So the cause for hyperosmolar hyperglycemic state is the most common precipitating factors is 1, noncompliance with insulin regimen, but usually it's going to be due to chronic dehydration. What happens in a patient who is chronically dehydrated? As they become if they don't, let's say they don't take their insulin, their glucose level goes up. As their glucose level goes up, they spill more glucose into the nephron and out through the urine. When there's more glucose in the tubules, that's going to draw fluid out. As you draw more fluid out, you become more hyperosmolar. You become more dehydrated. And the more dehydrated you become, the higher your relative level of glucose is, because your glucose level is going to be higher when your blood is more concentrated. So dehydration, high glucose levels feed into the dehydration because it causes polyuria, and the polyuria feeds back into the high glucose level because it concentrates the blood. And so it's this vicious cycle going on. The symptoms are going to be acute loss of consciousness, decreased level of awareness, focal or global neurologic deficits, usually either global neurologic deficits. Sometimes you may see seizures, but a lot of times you're going to know that these patients have type 2 diabetes. Thirst can also be a symptom. It usually is a symptom, but if the patient is not aware, they might not relate that to you. And then polyuria. But if the patient is critically dehydrated, they may not have any urine. So look for focal and global neurologic deficits, acute loss of consciousness in a patient with known type 2 diabetes. The diagnosis, again, is going to be clinical and laboratory. The most important labs here are going to be your fingerstick glucose, your CMP, your urinalysis plus dipstick, and your CBC. Your fingerstick glucose is going to help you diagnose HHS because patients with HHS are usually going to have glucose levels that are so high they're going to be almost always above 600 and even higher sometimes. Your CMP is important to help you find out your plasma osmolarity, and the UA and dipstick is helpful sort of to differentiate this out from DKA if you need to, and then a CBC is useful as well. Because there are neurologic symptoms, you're going to also want to get a CSF just to exclude any kind of trauma or any kind of infection. And then chest x-ray is useful. It's easy. You can look for infection there. Pneumonia is a very common cause of infection, particularly in elderly people where this usually strikes. An EKG is good to get, and then a CT of the head. So for diagnosis, the glucose level is going to be above 600 milligrams per deciliter, but often it's much higher. CBC, just like in DKA, the white blood cell is going to be increased regardless of whether there's an infection or not, but the left shift is going to suggest an infection, and you should culture the blood. Urinalysis, you get a dipstick, it should be highly positive for glucose, but not so much for ketones. Urinalysis will confirm this, and you should culture the urine. As far as your CMP, the electrolytes are going to vary. They're not going to be as cut and dry as DKA. But what you will see in hyperosmolar hyperglycemic state is a high serum osmolality, and that's because you're peeing a ton, and so your blood is just getting more and more concentrated. So often it's going to be greater than or equal to 320, and that's really high. You're also going to see, because of the dehydration, you're going to see azotemia. And what's azotemia? It's just an elevated BUN. And so an elevated BUN with a prerenal picture will be seen. Prerenal azotemia comes from dehydration. And so because we have less perfusion to the kidneys respond, and the creatinine level goes up, the BUN level goes up even more. And so the BUN creatinine ratio will be greater than 20:1, and that is a prerenal azotemia picture. And if you can't remember that, go back and look at the prerenal azotemia section that I did in the nephrology section. So azotemia with a prerenal picture really points us towards hyperosmolar hyperglycemic state. Okay, the treatment for HHS, the primary goal is going to be to replenish fluid volume. So why do we want to replenish fluid volume first? Insulin replacement is secondary. Because in these patients, the primary problem is that they are dehydrated, and this can be deadly. So the primary goal first is to replenish the fluid volume. Plus, because we don't know if they're hyperkalemic or hypokalemic or normokalemic, if we give insulin, they may go into very deadly hypokalemia. So we want to get their fluid volume replenished first. So in unresponsive patients, the very, 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 very first step, of course, following your ABCs, is going to be to secure the airway. Now, after you've done that, or if the patient is responsive and breathing, you should give 1 to 2 liters of normal saline over the first hour. And then the rule of thumb is generally to replace half of the estimated fluid loss in the first 12 hours and the other half in the next 12 hours. Meanwhile, you should be getting serial CMPs. Why? Because you want to look at the electrolytes and you want to look at how the kidneys are doing. Once the azotemia has resolved, so once you're between 10 to 20 to 1, so a BUN creatinine ratio between 10 and 20 to 1, then you've resolved the prerenal azotemia. At that point, then you can start insulin. So once the azotemia is resolved and a normal BUN creatinine ratio is established, you can start insulin. Just like in DKA, you're going to want to monitor your potassium while you're giving insulin, because insulin causes the blood potassium to drop. And so the insulin therapy, just like in DKA, is regular insulin. It's 0.1 units per kilogram per hour, and we're going to target a glucose between 200 and 300 milligrams per deciliter. At that point, then the patient can be brought back onto their oral therapy. So remember that the potassium will drop once the potassium hits 5 milliequivalents per liter, which it will, and oftentimes it will before you get back down to 300. You'll want to start potassium chloride, 10 milliequivalents per liter in their IV at once it hits 5 milliequivalents. As far as how their disposition, once the patient is stabilized and they're in the 200 to 300 glucose range, and an underlying cause is being investigated, you should transfer them to the ICU or to the general wards. Generally, if they need a secure airway, you're going to be transferring them to the ICU. Otherwise, the general wards or an intermediate ward would be fine. Neurological sequelae will often last for weeks, even once the glucose and everything else has been corrected. So a lot of times they're going to need to be in the hospital for a while, and you can step them down to the wards from intermediate or to intermediate from the ICU. But usually they're going to need to be in the hospital. Once the patient is discharged, once the patient's neurologic symptoms have improved, then you can discharge the patient as long as they're able to sufficiently care for themselves and for their oral medication and insulin regimen and their own glucose monitoring. You should consult an ADA diabetes educator if one is present, or give the education yourself as far as making sure that they're taking their diabetes drugs or their insulin. And you should also consult social services, particularly if the patient lives alone, if they live in a nursing home, because generally patients should not get like this. This comes from, yes, both not taking your insulin, but it can also come from severe dehydration. So if the patient's in a nursing home, we're wondering what's going on. And this can be associated with elder abuse. So social services can be an appropriate consult in this case. And then home care can be useful if the patient lives alone, just to help them do appropriate measures at home to keep this from happening again. And for information on chronic complications, including neuropathy, nephropathy, and gastroparesis, see the lecture on outpatient management of diabetes mellitus. And that's it.